Good evening, everyone, all those of you who have joined here today. So, today this is part one of a webinar series that we are going to do over the next few weeks. And today we have two very distinguished speakers with us who are international authorities in their respective fields of work. One is Dr. Rajesh Botchu, who is, I will just Dr. Rajesh Botchu, I don't think he needs much introduction, but he is a consultant musculoskeletal radiologist at Royal Orthopedic Hospital in Birmingham. Uh, he has extensive experience in imaging and interventions of sarcoma and musculoskeletal radiology, pretty much every single aspect of it in general. And he is also a part of the faculty that the course that we are doing in Mauritius in the end of September 2026 to 25, which is the International Muscular Summit. He will be there as a faculty too. And today, Dr. Botchu will be discussing with us the role of fat in musculoskeletal radiology, how it helps us many times, how it is not so helpful sometimes, how it confuses sometimes, some learning pearls, how we can use fat to our advantage, and how to avoid some pitfalls wherever we encounter fat. So Dr. Botchu will be discussing. On to Dr. Botchu. So you can share your screen. Dr. Avneesh will be after you. And any questions, anyone, any of you have any questions, please feel free to ask. Just post all your questions in the chat, and at the end of the talk, we will reply to all the questions, and it'll be more like a informal discussion at the end of the talk. So you're not audible. You have to turn on your audio.
Can you hear me now?
Yes, we can hear you.
Okay. Can you see my presentation? Yeah. Yeah? You can hear me and see me,
Yes,
yeah?
sir.
Okay. Yeah, thanks for joining everybody. So good morning, good evening, and good afternoon, depending upon which part of the world you are seeing this webinar from. So my name is Rajesh. So I'm actually an orthopedic surgeon. Now I'm a musculoskeletal radiologist, and I'm based at the Royal Orthopedic Hospital in Birmingham. And today I'm going to talk about fat. And the problem with fat is that nobody likes fat as a general because they always try to cut weight. But for MSK radiologists, fat is one of the crucial component whenever we look at ultrasound, X-ray, or MRI. And today what I'm going to do is I'm going to show you a spectrum of cases and spectrum of how I use fat to help me in identifying or making the diagnosis or assessing my response. If you want to see lots of cases of musculoskeletal radiology, we have a free website and app called MSK Radiology for You. And it's got over 4,000 cases, which is free. And there are quite a few interactive lectures as well. And it's also available as an app in English and in Mandarin as well. So whenever you look at fat, so normally whenever you look at fat, you have several lesions that can contain fat ranging from simple lipomas to hemangiomas, fibrous dysplasias, infarcts, infection. We will show you the role of fat in that. Radiotherapy, yes. What is the role of how fat can help us in assessing response to radiotherapy? I'll show you some cases and how it can help you to assess if whatever treatment you have done has responded. So that's how we'll go in an order. In order to look at fat, there are certain sequences. So my talk is mainly MR based. So if you want to look at fat, the way to identify fat is the signal will be similar to what you see in the subcutaneous tissues. So if you can see, the normal sequences are T1, T2, and PD. So they should be bright on those sequences. And whenever you suppress the fat signal, either using T2 fat sat, T1 fat sat, proton density fat sat, or STIR, there should be homogeneous signal suppression. If you can see gross fat, that's how you can suppress. However, if you want to see microscopic fat, then chemical shift is very good. It's 100% sensitive and around 94 to 100% specific. So, in a study that was done in our center by Dr. Davis and Dr. James, along with San Diego people, where they looked at 184 lesions, which included a spectrum of malignant and benign lesions, they found that benign lesions had about a quarter of them had fat, whereas in malignant lesions, only a minor, about 2 to 5% had fat. So, fat is very good whenever we see it, it implies benignity. So if you look at cases, for example, this is a case of a patient with left hip pain, and they had an X-ray which shows a well-defined lucency involving the left proximal femur. Given the age, there's a wide differential. However, when you do MRI, what we can see on the T1, you can see that it is bright on T1, and on axial, again, it is quite bright. Whereas when you do fat suppression sequences, in this case, we used a T2 fat sat, you can see there is homogeneous signal suppression. So this is fat intraosseous lipoma. So it should not be difficult to identify what it is, but it is important to know that it can, on X-rays, mimic tumors. Similarly, what about this one? Again, a patient presented with ill-defined pelvic pain, and on the radiographs, what we can see is a lucency involving the ileum, the right ileum here. When you do MRI, what we can see is, we can see on T1 there is a high signal within the iliac blade with slight expansion of the cortex. Whereas on fluid sensitive sequence, you can see there is almost homogeneous signal suppression with a small center focus of cystic change. Remember, if it's a small intraosseous lipoma, it will show homogeneous signal suppression. However, if it is quite big, then you're allowed a bit of cystic change, a bit of calcification within it. So that does not mean liposarcoma. That still means intraosseous lipoma. And on the coronal, again, you can see how when compared to the left, there is expansion of the cortex, and this is the lesion demonstrates homogeneous signal suppression on fat suppression sequences. So it's quite easy to diagnose. This is a classic X-ray that everybody would have seen, where there is intraosseous lipoma within the calcaneum, and in this case, you can see a small focus of calcification. Look at MRI, quite bright on T1, so that's quite easy to diagnose. What about this one? In this case, what we can see is ill-defined pain in the pelvis. X-ray is pretty normal. When you do MRI on the T1, you can see this lesion involving the right posterior ileum. It is slightly hyperintense. As a rule, in musculoskeletal imaging, we always compare the signal to muscle. Okay. If the lesion is brighter than muscle, we are quite happy. It can be some sort of variant, lipoma variant, as in this case. This is a case of a hibernoma. You can see the signal is higher than muscle. When you do fluid sensitive sequence, you can see that it is still bright. And then on CT, you can see that there is increased density, and on biopsy, it turned out to be a hibernoma. So the take-home message is that if the lesion is brighter than muscle, it is unlikely to be anything sinister. And if you do bone scan in these cases, it can show a focus of increased uptake. What about this one? A patient with shoulder pain, what we can see that there is a lesion involving the glenoid, there is expansion, there is a bit of fat, a bit of trabeculation, and on stir it is bright with some low signal lesion within it. And on the planning CT, we can see what there is coarsening of trabeculae within it. The second concept that I would say is that, as a rule in musculoskeletal imaging, majority of the lesions are described in the spine or in the knee. So if you have a lesion which is not in the spine or the knee and you're not sure what it is, I would suggest you take the lesion off from that area and put it in the spine or in the knee, and you'll get your diagnosis. For example, if I have this lesion in the spine, I know my diagnosis is hemangioma, and that's what it is. Similarly, another case, patient with incidental finding of abnormality involving the tibia. You can see this lesion involving the cortex predominantly, and on fluid sensitive sequence, you can see the appearance similar to that of a hemangioma. In this case, he's got an intraosseous as well as a small extraosseous hemangioma. And on CT, classic appearance of hemangioma, and that's what it was on biopsy as well. You can see hemangiomas in different bones, and depending upon how big they are, they can have varied appearance. For example, in this patient, we can see this lucent lesion involving the calcaneum. When you do MRI on the T1 sequence, you can see there is fat and these are vessels. fluid sensitive sequence, again, you can see the vessels and fat. So this is a large intraosseous hemangioma or vascular malformation. If you have a tumor will normally displace the fat. Whereas if it is a hemangioma or any benign lesion, then the fat will still be retained within the lesion. So hence, based upon the imaging, if you see some fat within the lesion, you know that it's not a sinister lesion. So this is a case of intraosseous hemangioma again. What about this one? Patient with ill-defined pain had a bone scan, and on bone scan you can see multiple osseous lesions involving the right femur and right tibia. And when you do MRI, you can see there is an expansion, destruction, the cortex is destroyed. Fluid sensitive sequence, it's still high signal, the cortex is destroyed. Obviously, we are worried that it can be something sinister. In these cases, you can use chemical shift imaging, and I'll talk about chemical shift imaging in the subsequent slides. But when you do chemical shift imaging, if it shows signal drop off of more than 20%, you know that there is intraosseous fat. And in that, when you see intraosseous fat, then you can say that it is nothing sinister. And in this case, it was a biopsy-proven multifocal hemangiomas as well. And if you do whole body MRI, you can see, like in this case, patient has got multiple lesions involving the sacrum, the pelvis, the stir axial showing multiple lesions involving the sacrum, ilium, spine, both on fluid sensitive sequence as well as on T1. And on stir, you can see multiple lesions involving the lumbar spine and sacrum. So how do we make the diagnosis? The options are you either do chemical shift imaging or you can do a biopsy of one of the lesions. And in this case, if you look at the X-ray, you can see multiple sclerotic lesions. So the most common differential that everybody would say is multiple Mets. And that should be one of the top diagnoses. However, if you think that there is some intraosseous fat, either on chemical intralesional fat on chemical shift imaging, or which means a signal drop of more than 20%, or on biopsy, then you can make the diagnosis of multifocal intraosseous hemangiomas. That's what it was in this case. Again, you can see the X-ray, multiple sclerotic lesions in the same case. She had multiple lesions even in the glenoid. And if it is symptomatic, this is what we can do. And this patient was quite symptomatic, especially in the lower back. So what we did was we injected some cement into the hemangiomas within the sacrum, and she was pain-free. You can have lesions like this as well. In this case, on bone scan, you can see a focus of uptake within the right proximal femur. On MRI, note that there is an ill-defined lesion on the T1 and on fluid-sensitive sequence. But based upon the sequence, we know that there is some intralesional fat. The moment you see intralesional fat, you know that it is a benign lesion. And this was, again, a case of intraosseous hemangioma. So hemangiomas are quite common, and majority of them are seen in the spine. They can be seen at any age. They're slightly more common in females. They can be multiple in about a third of patients. And if you see in the spine, predominantly, you will see it in the vertebral body, very rarely in the posterior elements as well. Depending upon the composition, if it is predominantly fatty, then you will see the classic appearance. However, if it's predominantly vascular, that's when you need to use chemical shift imaging. And I'll show you some cases. So the typical hemangiomas will have a lot of fat, and atypical hemangiomas will have more vascular component. There is a component called aggressive hemangioma, and that is when there is cortical destruction. There is an extraosseous component, and they can present with either rapid growth or cord compression and or associated neurological compromise. And I'll show you some cases. So on the typical appearance of hemangioma in the spine on radiographs is reduced bone density and what we call as honeycomb or corduroy pattern. And if you do CT, what you see is this punctate calcification or polka dot appearance. On MRI, typical appearance, you will see if it has got a lot of fat, it will have similar features of fat that is high on T1, high on T2. You can see some vessels within it. And on stir, it can be slightly hyperintense. We don't give contrast, but if you give contrast, it can show variable enhancement. If the lesion has predominant a vascular component, that's when you can get confused. In those cases, it will be iso or hypointense on T1 and high on T2 and fluid sensitive sequence, like this one. You can see that there are some high signal within it, T1 high signal within it. And on fluid sensitive sequence, it gives you mixed appearance, predominantly high signal. However, because there is intralesional T2 weighted T1 high signal on the axial, so we have a hunch that it could be atypical hemangioma. So in these cases, if you can do chemical shift imaging and show that the signal drop-off is more than 20%, you can confidently make the diagnosis of atypical hemangioma. And that's the classic CT appearance. Aggressive hemangioma, as I said, normally what you can see is you can see destruction of the cortex, you can see extraosseous component or soft tissue mass, and they can be associated with cord compression or neurological compromise. As in this case, you can see aggressive hemangioma with soft tissue component within the spine, causing a bit of spinal canal narrowing. Or, as in this case, involving both the vertebral body and posterior elements, there is a bit of perilesional edema, but the spinal canal itself is still patent. And if you do bone scan, they can show increased uptake. So aggressive hemangioma, again, if you want to confidently make the diagnosis, you should always use chemical shift imaging. You might note that I've been using chemical shift imaging during my slides multiple times. And as a rule, in all our sequences, we use chemical shift imaging, irrespective of the pathology. In fact, it's become a default protocol because it only takes 13 seconds to do. And in some cases, it will help. So as a default, we have chemical shift imaging on all our sequences. Another case of atypical hemangioma, in this case, we have vertebra plana, you have got bowing of the cortex, extraosseous component, cord compression. But the typical appearances of on T1, fluid sensitive sequence along with chemical shift and CT helps you to make the diagnosis. Another case here, you can see typical hemangioma with an extraosseous component causing a bit of spinal canal narrowing. What about this one? So what we have here is we've got abnormal lesion within the vertebral body. But note the signal characteristics of the two lesions are different. The one anterior is high on T1 and T2. The one posterior is low on T1 and high on T2. So this is where we have two lesions within the same. So this is on chemical shift imaging. Both of them showed signal drop-off. So this is the combination of typical hemangioma and atypical hemangioma. What about this one? We have got a patient with a typical hemangioma within the vertebral body. However, on the left side, you can see this lesion, which does not follow the signal of typical hemangioma. And when we do chemical shift imaging, it did not show signal drop-off. Similarly, another patient with hemangioma in the vertebral body, but there is another lesion here which does not show significant signal drop-off. So I'm talking about that lesion. Majority is hemangioma, but that lesion is not. So whenever you look at any MRI lumbar spine, and if you have follow-up of previous imaging, you should always compare with previous imaging to ensure that there is no change within the hemangioma. If you don't compare, then you will miss things like this. So these two are biopsy-proven renal metastasis. So as I was saying, whenever you think that it could be hemangioma, but you're not sure, that's when you use chemical shift imaging. And in chemical shift imaging, depending on what protocol you use, you get an in and out phase, and you put the area of interest on that lesion in both in and out of phase. And the magic number is 20%. If there is a signal drop off of more than 20%, that means it's more likely to be benign. What about this one? So here we have a lesion within the sacrum, and this is what we do. You get an in and an out of phase imaging, and when you put the area of region of interest, in this case, you can see that it was 184 in the in phase, and in the out phase is 55. So definitely more than 20%. We can confidently make the diagnosis of hemangioma. And you can see how confusing it can be on the stir sequence. Similarly, the case that I showed you before, you can see that there were two lesions, different characteristics within the vertebral body, but both of them show significant signal drop-off. 160 here, 230, 95, and 150. But because the signal drop-off of is more than 20%, it does not need biopsy. What about this one? So another patient with back pain, we have got lesions involved. There are two lesions, one on the upper part of the spine, one in the mid spine. And when you do chemical shift imaging, you can see the lesion. This one shows significant signal drop off 334 and 221, whereas this vertebral body lesion does not show significant signal drop off. And this was a biopsy proven breast metastasis. So chemical shift imaging is very good to identify intralesional fat. And based upon that, you can say whether it is a hemangioma, atypical hemangioma, aggressive hemangioma, or it's a MET. The same here. So as I said, hemangiomas can be typical, atypical, or aggressive, and chemical shift imaging is the key. Similarly, this is a patient who presented with back pain, and it's not uncommon to see heterogeneous marrow signal or multiple lesions within the spine. For example, in this case, patient has multiple lesions at L5, L3, and even in T12. And when you do T1, you can see there are still, the lesions are still intermediate to low, whereas this one is definitely brighter than muscle. So we have a hunch that it can just be a red marrow. So in this case, what you can do is you can do chemical shift imaging. And when you do chemical shift imaging, it shows that there is significant signal drop off. So you can confidently say that these are foci of red marrow. Another patient presenting with typical hemangioma features, bright on T2, bright on T1, very easy to diagnose. But when you follow this patient up on the subsequent imaging, we found that she had developed this small focus of abnormal signal, which is low to intermediate on T1 and T2. Because it did not follow the signal features of hemangioma, we biopsied this. And it turned out to be a focus of red marrow. So within the hemangioma, you can get atypical hemangioma, focus of red marrow, you can get metastasis as well, as I showed you before. So focus of red marrow, once you diagnose, it's very easy. It's not, but it can mimic metastasis. It's important to identify it. And it's common in patients who are smokers, who do excessive sporting activities. So the lesion that I showed you where you had two different pathologies, hemangioma with focus of red marrow, hemangiomas with atypical hemangioma, hemangiomas with metastasis. That's what we call as collision lesions. These are very common in non-MSK, but in MSK, we were the first to describe collision lesions. And if you want to read about it, you can read about it in our paper on spinal collision lesions in Journal of Clinical Orthopedics and Trauma. So the take-home message for the first part is that if you suspect that it could be hemangioma, atypical hemangioma, it's always better to review previous imaging and to do chemical shift imaging as far as possible. And then if you're still in doubt, then do biopsy. What is the second most common cause where you see fat, bone infarcts? Obviously, if you see a lesion which is geographic, multifocal, it's quite easy to make the diagnosis of bone infarcts. And when you do MRI, what we need to see is we need to see that there is fat within the infarct. Okay. So why is it important? For example, in this case, we have got infarcts involving the distal femur, proximal tibia, and it's got fat. The reason is we have had several cases where there was fat and suddenly the fat was replaced with tumor. What I'm trying to say is that malignant transformation or malignancy within infarcts is extremely rare. However, the only way you can identify is when the fat is lost. And we published our paper where we showed that there were 14 cases of secondary sarcomas within bone infarcts. The take-home message is that bone infarcts are common. You can diagnose it. Make sure you can see homogeneous fat within it. And if there is suspicion of destruction anywhere, that's when you should suspect that there is malignant transformation. What about this one? This is a classic lesion. You can see quite commonly it's an incidental don't touch lesion, lucent lesion involving the right femoral neck. On T1, you can see that there is narrow zone of transition and there is some intralesional fat. And on fluid sensitive sequence, we can see that there is fat and cystic component. The moment you see, you can make the diagnosis. This is a case of cystic fibrous dysplasia. It's a don't touch lesion. Infection. So the most common mimic of tumor is infection. And I would say if you're doing MSK intervention, for example, any biopsies of any suspected bone or soft tissue sarcoma, you should always send 3 samples for histology and 1 for microbiology. And the reason is infection is a great mimicker of tumors. So what do we have? How does fat help? So this is a patient with barn door osteomyelitis involving the distal metadiaphysis as well as the epiphysis of the tibia. And we can see these fat globules within it. The moment you see fat globules within a lesion, you know that it is benign. And in this case, it's osteomyelitis. Same again, a patient with osteomyelitis with large periosteal correction. It is osteomyelitis, but if you want to get your confidence up on T1, you should see intralesional fat. The same here, patient with osteomyelitis, multiple fat globules within the lesion. And if for example, this one, it's an aggressive lesion involving the distal femur. You might think it's an aggressive lesion, either osteomyelitis or Ewing's. And when you do MRI, you can see intralesional fat. The moment you see fat globules, you should be happy because it is not tumor. So this is just osteomyelitis. Same again on fluid sensitive sequence, you can see that there's a lot of edema and there are fat globules. T1 post contrast, we don't use post contrast nowadays. What about this one? We've got a permeative lesion involving the proximal humerus, and there's probably a undisplaced pathological fracture as well. So the differential is either an aggressive lesion like an Ewing sarcoma or lymphoma or osteomyelitis. So how do you diagnose? Just do MRI, and in this case, we can see fat within the medullary cavity as well as extraosseous. You can see fat globules within the medullary cavity and extraosseous. The moment you see, again, you can confidently make the diagnosis of osteomyelitis. Same again, another patient with osteomyelitis with multiple fat globules. You can confirm the same at T1 on the axial as well. And this is post-contrast. We don't use post-contrast nowadays. Another patient with osteomyelitis, again, note multiple fat globules. I'm showing you multiple examples of different locations of the similar pathology to reinforce the importance of fat globules or whatever concept I'm saying. Rather than showing one case, I'm just showing you how it can help you to confidently make the diagnosis. In this case, again, multiple fat globules within the patient, within the distal tibia in a patient with known osteomyelitis. If you do fluid sensitive sequence, you can see they're all suppressing. So we can confidently make the diagnosis of osteomyelitis. This is the case I showed you before. Radiation. So whenever a patient has radiotherapy, you can see changes that can mimic tumors. For example, in this case, if you have an X-ray, you can see this ill-defined white zone of transition, permeative lesion with tunneling. The moment you see that, you will think that probably this patient has got myeloma. And this patient also has got a stress fracture or insufficiency fracture involving the fibula as well as the lateral cortex of the tibia. But when you do MRI, you can see that it's predominantly fat. And fluid sensitive sequence will help you to reinforce the same finding. And you can also see soft tissue edema. The moment you see tunneling within the cortex or edema of the soft tissue, you can make the diagnosis of radiation osteitis. Why is it not radiation-induced sarcoma? In radiation-induced sarcoma, the first thing is it will take a minimum of 5 years from the time of radiotherapy to develop radiation-induced sarcoma. That is the first thing. Second thing, you should have non-fatty component. And in this case, we can see most of it is just fat and a bit of edema. What about this one? We can see this permeative lesion involving the humerus. And this one in case of distal humerus and proximal radius. But when you do MRI, you can see it's predominantly fat. And the moment you see this, you should think either that the patient has radiotherapy or it could be disuse. Post-radiotherapy, they can have insufficiency fractures. In this case, patient has had bone scan, which shows increased uptake within the sacrum. When you do MRI, you can see that the radiotherapy change within the posterior ilium and insufficiency fractures of the sacral ala bilaterally with edema. So if the patient has severe pain, it's quite easy. You can just put cement in, what we call a sacroplasty, and the results are amazing. As a musculoskeletal radiologist, I would strongly advise you to do some intervention, because going forward with the role of AI, if you do intervention, it will always help you to preserve, or your job will be safer. Whenever you do any treatment, either ablation, cryotherapy, sclerotherapy, PAT will help you to assess if there is response. What we are looking for is, we are looking for fatty infiltration within the lesion. So I'll show you some examples. So this is a case of a chondroblastoma involving the proximal humerus. You can see on the X-ray lucency involving the proximal humeral physis. I did cryotherapy. You can see multiple needles. The lesion was quite big, so hence we cannot do RFA. I did cryotherapy, and what we are expecting to see is fatty change. And now you can see that the lesion is replaced with fat, and that's what we can see on the fluid sensitive sequence. And there is no perilesional edema, so that's a good response. So this is what we do in cryotherapy. You freeze the lesion to minus 40 degrees, and then it helps to treat the tumor. We can use multiple needles. We can use up to 20 needles to do cryotherapy. Uh, that's my team. So this is what happens. So you do multiple lesions and you just freeze them, and that's how you can treat it. In RFA, we use heat, whereas in cryotherapy, we use cold, extreme cold, which we use by using argon gas. We create the ice ball, and that helps to treat the tumor. Another patient, you can see this lesion involving the left posterior ileum. So this was a chondromyxoid fibroma. Patient was symptomatic, hence we decided to treat. Surgeon was not happy to treat, which is because most of the times it's a benign lesion, but patient was very symptomatic, so we did cryotherapy. We put the needle in, 2 needles, and we did cryotherapy. And on post-treatment scan, you can see that there is fat within the lesion. The moment you see fat within the lesion, you should be very happy, and you can see fat and a bit of cyst, and that's what. So fat is very good for us to see whether our treatment has helped or not. Another patient, you can see lesion involving the proximal humerus, and post-treatment, there is fatty infiltration, post-cryotherapy. Another patient involving the greater trochanter lesion, post-cryotherapy, you can see that there is fatty change. So the moment you see fat, you should be happy. The other reason why we use chemical shift imaging is we rely on chemical shift imaging to show continuity of fat. For example, whenever you do MRI, it's quite difficult sometimes to see past defects. This is classic. You do a CT, but nowadays CT causes a lot of radiation. So instead of that, what you do chemical shift imaging. And when you do chemical shift imaging, on the out of phase imaging, you can clearly see that there is a past defect, whereas that past is intact. So as a routine, all our imaging, lumbar spines in particular, will have chemical shift imaging. So it helps you to identify indeterminate lesions and also for past defects. Another patient, intact past defect, and when you do chemical shift, you can see the past defect. And if you want, you can read our paper. Sometimes all that glitters is not gold. In this case, on T1, you can see these high signal lesions, whereas on fluid sensitive sequence, it does not suppress. So you know that it's not fat. So this is a case of classic chordoma. So it's a pseudo fat sign. So what I have tried to show you is that fat can help you to identify help you to identify what it is, can help you to identify what's our response to treatment as well. But at the same time, ensure that you use chemical shift imaging to identify other abnormalities like past defects. But be careful to compare the signal on T1 and fluid sensitive sequence to avoid errors like this. Thank you for that. And then if you want to learn more about musculoskeletal radiology, in particular hands-on ultrasound or MRI workshops, I would strongly advise that you attend the International Musculoskeletal Summit at Mauritius. And also, if you want to embark on a research journey, then it will help you to, if you can attend, because, for example, after the first international summit, I can tell you that I have published papers with all the people in the faculty and quite a few of the members. So I think it will help you to have a good holiday. At the same time, learn from the experts like Avneesh Chhabra, Girish, Varaprasad, Nizar as well. So we hope to see you all there. Thank you.
Thank you, Professor Botchu. I think that was an absolute masterclass on how fat can help us significantly in getting confident with our diagnosis, and how there's a wonderful role of chemical shift imaging in helping us decide between the benign and malignant diseases. Next, we have a couple of questions for you, Dr. Botchu. I think we'll take them now, and then we'll move on to Dr. Avneesh talk. So the first question is, you showed a case, a red marrow case where there was a hemangioma with red marrow. So the question is, should we not be evaluating it for microscopic fat instead of performing a biopsy, that particular case?
See, biopsies always have a risk. If you can try and answer the question with chemical shift, that's good enough. If it is indeterminate, then only you should use biopsy. That's my opinion. So ever since we have started using chemical shift, maybe 10 years ago, the number of biopsies that we have been performing has decreased significantly. And in our experience, chemical shift is pretty good. And touch wood, we have never been caught. So I would strongly advise do chemical shift imaging first. And if you can get the answer, that's fine. If it still does not show signal drop off, then only go for biopsy.
The question here was in that particular case, you did
Yes.
a biopsy. So the
Yes.
question here is why did you do the biopsy in that case?
Because the signal drop off was just borderline and it had developed following patient has had a few previous scans for some other cause and it had developed and the signal drop off was I think about 18 or 19 something like that. It was not more than 20% barn door. So in some cases you will it looks like atypical hemangioma or something which has got fat, but chemical shift is just not confident enough. That's why we did the biopsy in that case.
Got it. The next question is the presence of post-treatment fat enough so that we don't have to give contrast in
Yeah.
these cases?
Yeah. So I don't give any contrast. Okay. In our center, we are a tertiary hospital. We do about 60 or 70 at least MRs for bone and soft tissue tumors. We don't give contrast to any because we feel that the diagnosis is already made on the non-contrast sequences and it does not help anymore. First thing. Second thing is there is a lot of controversy about the role of contrast because it can get deposited in the skin, brain, and bones as well. So we have taken the role that we have taken the decision that just with simple non-contrast imaging we can make the diagnosis, and that's what we have changed for. And we only changed after the papers that have come on anthropogenic gadolinium. So even for arthrograms, we don't use contrast. We use normal saline or local anesthetic. And by changing the sequence, we get nice arthrograms. So the only indication for contrast in our center is post-spinal surgery or in cases where there is confusion whether it is recurrence or not. And more often than not, we can make the diagnosis on the index scan.
Got it. I think that answers it very well. Last two questions are how to differentiate focal red marrow from fat poor hemangioma.
Focal red marrow, both focal red marrow normally will be high signal, and if you do focal CT, it will be hyperdense as well, high attenuation as well. So that is one way of diagnosis, focus of red marrow. But in some cases, it may be tricky, but the location appearance on MR will help you. But both of them will show chemical more than 20% signal drop off, and both are just incidental findings.
Thank you. And the next question is why can't we do fat fraction with T2 Dixon?
You can use that. Yeah. Depending upon some people use Dixon. I'm sure Avneesh Chhabra is going to talk next. He loves Dixon. We just, everybody has different preference. You can use the same with Dixon. We use box standard chemical shift on Siemens, but you can do fat, the 4 sequences that you use for Dixon as well.
Got it. And we'll take the last question. The last question is regarding intervention. When you do cryo, do you do follow-up MRI imaging? And if you do, then when?
So normally every cryo, we have a standard follow-up protocol. So we do pre. So that is the other indication for contrast, yeah. Because in cryotherapy, we want to see which is enhancing. For example, fibromatosis, that is there we use contrast. So we do pre, post we do in 3 months, 6 months, 1 year, and we follow it up for 2 years. And then, so we have done about maybe 80 to 100 cryotherapy cases. So that's our protocol. 0, 3, 6, 1 year, and then 2 years.
Thank you. I think that answers the question very well. The last question, and we'll move on to the next topic. Last question is, do collision lesions have to be contiguous?
Contiguous means it will be within the hemangioma. So if you have the hemangioma, it will be somewhere within the hemangioma. So it will be within. So if you look at the hemangioma, you should see classic appearance. If you can't see any classic appearance, you know that that thing is not raw, not the signal as a hemangioma. It has to be red marrow, atypical hemangioma or MET. So you can compare, do chemical shift, and make the diagnosis. So that's what I think.
Perfect. Thank you, Dr. Bochu, for your excellent talk and for answering all the questions so well.
Thank you.
Next, we will move on to the next speaker, the second speaker for the day, and who is none other than Dr. Avneesh Chhabra. I don't think he needs any introduction, and there's no one in the world who is really interested in MSK and doesn't know him. So, Dr. Avneesh Chhabra is a professor of radiology and chief of musculoskeletal radiology division at Southwestern Medical Center in Dallas, Texas. And he's a global authority in the field of MSK MRI. And uh, he will be talking to us today on Sweet 16 signs on MR neurography to increase your diagnostic accuracy. So, over to Dr. Avneesh.
All right. Well, thank you all for joining. I know it's evening time for some of you. It's morning here in Dallas. So we just finished another meeting, the second meeting. And thanks to all of you who contribute to our discussion group. I'll share the QR code in the end of the PowerPoint in case you still want to. There's some background noise here. So I see almost 140 people here. How many of you coming to Mauritius? Try to make it. It'll be fun to meet all of you in person. Dr. Sharma and us, we have organized this nice conference there. My first time there in Mauritius, but I think they had one last time which was very successful. And you heard Dr. Botchu's nice talk and how everybody has published with him. He's very prolific in publishing. So these are my disclosures, but I will. Okay, so neurography. I don't know how many of you are doing neurography. If you're not, you should do it because there is no competition for this. And it helps a lot of clinicians. So we work with plastic surgeons, hand surgeons, neurologists, physical therapists. So a lot of people, they refer these cases. And what neurography is similar to angiography, basically display of nerves in different dimensions, not just looking at axial scans. And then importantly, treat peripheral nerve as an organ system. So just like liver, spleen, etc., you look for fat, hemorrhage in the nerve. You should look at it in the peripheral nerve also in detail, what's going on. And just calling the nerve bright or muscle denervation is not enough because patient knows they have a foot drop and then clinician knows they have neuropathy. So just confirming that is not enough. That's what EMG is doing. But with MRI, we'll discuss certain signs which can help you make that diagnosis. But before we get to signs, we're a little bit delayed. I'll run through this quickly and then get to the signs. So use your highest field scanner, 3 Tesla if possible. The newer 1.5 Ts are as good as 3 Teslas, the older ones. So I started with Vario scanner several years ago, 15 years ago, doing neurography. And now the new Solas and 1.5T scanners are also as good. Break the field of view. So if you're asked to do brachial plexus, whole arm, etc., break it up, meaning upper arm separate, elbow separate, forearm separate, and then stitch it together. So that way you don't have too much blank space around the extremity and you're trying to magnify the nerve and making it blurred and all that. So break the field of view. Use flexible coils. Now we have contour coils, air coils, etc., which can wrap around the structure. So you don't get these sort of blank spaces at the brachial plexus. Or even if you're doing extremity, you don't need to do specific joint coil. You can just take a multi-channel flex coil and wrap it tightly around that extremity and stitch them together. Keep the matrix high as much as, in some cases, we have going up to 720 also, but at least 256 and above. And keep the echo spacing low. So that's how you're going to see inside the nerve what's going on. And echo time, so this goes back to your transverse magnetization curve, the T2 curve, which falls over time. So if you go above 60 milliseconds, you're dropping too much signal. And if you stay in this range, then you enhance the endothelial fluid so you can see the nerves better. And you can use any of these. So I've used Spear for a long time now. We have moved more and more to T2 Dixons because you can get multiple maps from it. And then for stir sequence, it's starting from negative. It's starting from minus 180 first, and then 90, 180, 180. So that means you're starting from very black area. So everything is very black. The fat is very black around. So any sweat, any vessels, you're going to see it. So you don't need really higher Ts. So stir is actually based on T1 contrast, not T2. It's a longitudinal relaxation which goes from negative to positive and it passes through zero. You do your stir sequence. So keeping an echo time of 20 to 30 is more than enough. If you're doing a 3D stir, then you can get to about 70 to 80 milliseconds. And this is the same patient had on 1.5 and 3T. So you may get areas of poor fat suppression or inhomogeneity more in 1.5T. On 3T, you get more homogeneous fat suppression. And then many of you send stir images in coronal planes and looking for brachial plexus. You got to send me in sagittal plane, or you got to look at in sagittal plane. That's where you will. So this is a reconstructed from the 3D stir, showing this denervation and all these nerves. But when you reconstruct, now you can identify C5 through T1 or the C5 and C6 forming upper trunk, then middle trunk, these two forming lower trunk. And then when you get to the cord level, then these are arranged in a specific fashion from anterior to posterior, lateral cord on the top, anterosuperior, then posterior cord and medial cord. And this lateral will become the median nerve, which is this one. And then posterior will become the radial nerve and the medial will become ulnar nerve. So this is radial nerve, this is ulnar nerve, and this is another pectoral nerve coming up. And in this plane, you'll also see the suprascapular nerve come from here to there, and then you'll see axillary nerve dipping down like this. You'll see musculocutaneous in the front. So all these nerves you can identify on the sagittals. So always do sagittal stirs, both sides, on neurographies of brachial plexus. Now, what about EMG? EMG, this was a recent conference in HSS in New York 2 weeks ago. And these are high-end EMG guys, and this is a slide from their own PowerPoint. They said we are rather unreliable, especially in the wrong hands. There's ordinal and coarse grading, meaning basically they have just mild, moderate, severe, 3 grades, where there's conduction block to totally absent response. They don't have any localization, and then it's just bunch of potentials. It's not designed well for surgical questions. Severe denervation, everybody knows, patient knows, clinician knows, so it doesn't matter what EMG shows. And the nerve conduction studies are only obtained on a few surface muscles. So in US, you have to do 5 areas to get $120. So they unnecessarily do multiple muscles and they miss the muscles you need to see. So it's rarely obtained proximal and distal to the injury site. That's what is going to help you in localization. It's followed by collateral reinnervation, which may happen. So you may have totally dead muscle, and EMG may still show some innervation potential up to 3 weeks after complete cut of the nerve. So that's why EMG electrophysiology in nerve conduction is not useful. And they are saying similar to ultrasound and MRI. That's not true. That's only true if there's a lot of hemorrhage in the area. Then you want to wait 2 weeks and do an MRI after that. But if it's not a dirt bike injury, etc., you can do neurography, and on the same day of the injury, you can find the problem. And then they have these bunch of other responses, which nobody knows how to make much sense of that. So new potential, reinnervation potential, sensory evoked, etc. So there's a bunch of stuff out there. So they're trying to improve it, but I don't know why to waste with a modality which is archaic, old, and then you have new stuff which can tell you more. The second point is the 3D imaging is essential for MRN. So those of you doing just 2D coronal T1 stir and calling it neurography, I mean, that's fooling others and yourself. Because if you do 3D imaging, what advantages do you get? So you can get to very high resolution, and your different sequence is going to different resolution. And there's a short talk, I can go in all the details, but generally all your stirs are about 1.4 to 1.5 millimeters. Your space, vista, etc. for the spine are at 0.9, and then the CIS 3D, Fiesta, TrueFisp, etc. they are 0.6, and each have different roles. So this one 3D stirs, etc. This is for your brachial plexus where you don't have any other good fat suppression, and then this is for your spine. This is for inside the spine or the thecal sac, and then you can interpolate it down to 50%. So 1.4 can go to 0.7 and 0.9 to 0.45 and all that, and it can give you even higher resolution. So it's acquired here and interpolated to 0.45. And those are your DES, Mensa, Pasif, etc. So Pasif I used for 15 years. Siemens could not get good Pasif on, so they took it out of the scanner. So they have more of a DES. They still have Pasif, but it's not as good. Philips has a better Pasif, believe it or not. And then Mensa, they developed in GE after the patent was over for neurography. In 2013, the patent went away after 20 years. Then they came around. Otherwise, GE was not ready to do neurography. So anyway, so all vendors have different sequences for you to work with. But 3D, what it allows you, it kills all the arterial signal. It also kills the venous signal in most part, but you may still have a lot of these veins. So this is a 2009 scan when we first optimized it, almost 16 years ago. And you can see at that time also we could get individual segments in any plane we wanted. So this was 1.5 millimeter at that time. And then this is BFFE on Philips or steady state, Clufis, Fiesta, etc. This is for intrathecal segments. So you can see the nerve roots, which are rootlets actually, not even roots, the ventral and the dorsal. These are normal ones. Here you have seromeningoceles, and you don't have much left here except one twig here, another one there. So these are all torn, and you see that stuff there. And the whole pathology is easy to depict on these 3D stars, and some of you do them now, and make a MIP out of it. So many of you just send images without MIPs, etc. When you make a MIP and correct in the axial plane, then you can compare individual nerve to individual nerve and do both sides. I know HSS only does one side because GE doesn't have a good variant for two sides, and they want to get higher resolution in one side. So you want to do two sides so you can compare. So C5 is your smallest nerve, then you have C6, and after the DRG it drops to signal. This is C7, it drops to signal about half of the signal. Slowly should taper, but here it's not tapering. You have these patchy areas of demyelination here, here, there. So that's a CIDP case. And then even when you have metal, a lot of people resort to 1.5 Tesla, but actually you can do a 3 Tesla because here we are looking for injury in the area of the shoulder. So, and these plates are not very heavy plates, so they will have minimal artifacts. So you can see here that even on 3 Tesla, you don't get a whole lot of artifact here on stars. So you can see these thick nerves, that's a class 3 injury. You can see the scarring where the nerves were injured on these T1s. And you can see on this specific image, all the nerves, the radial nerve, that's the median nerve coming down, and the ulnar nerve is hiding behind. So it's basically radial and median are most abnormal. So you see not only injury from the surgeries they did, this is called PSIN, post-surgical inflammatory neuropathy. And there's also downstream neuropathy in the arm. So you can pick up with all this despite metal. So start with 3T, and if it gives you too much artifact, then you can move to 1.5. The last technical point is diffusion imaging is important, especially for small nerves when we are distinguishing, say, genitofemoral, genital branches from vessels or pudendal nerves from different vessels in the area. To look for subtle signal changes. So diffusion is very sensitive. So it'll show you increased signal of the nerves when it's abnormal unless it's scarred down. And for tumors, you can do ADCs, etc. So even if you're not doing DTI, do DWI. So here is a tumor which looks ugly. Doesn't have much edema around it. Usually MPNSTs have edema around it. But you can see the ADC is quite low. And then here's the ADC. It's like, I can't read it, but it's about 1.0 something. And then this was a malignant peripheral nerve sheath tumor here. Now we do DTI in our practice, so I'm not doing tracts routinely, but if it's a VIP patient, then I load it on the software because I have to spend about 20-30 minutes to make those tracts. So here you can see all these disrupted, distorted tracts from another malignant peripheral nerve sheath tumor. And then you can see these areas are small areas of necrosis, very high PET uptake. So when PET uptake is more than 6 to 7, or there's increased delayed uptake, usually it's a problem. But PET can fool you, especially in schwannomatosis. They are never malignant, and they can show you PET uptake of 8, 9, 10, maybe just benign tumors. There's a case of lymphoma with all these tracts are mostly maintained, but they're distorted, partially disrupted, and very low ADC, 0.8. So that tells you it's a lymphoma. So even if you're not doing DTI, use DWI. So here's a lesion which looks like a target sign. So this was 3 years ago, and the ADC was 2.1 or something. And then they followed after 2 years, and the mass remained stable in size. ADC went to 1.6, and you can see there are clear boundaries around the mass. Now they did another one recently, and some of these images may be distorted by the neck artifact, but still you can measure all the ADC, etc. So now it went to 1.3. So gradually it's going from 2.1 to 1.3, and you start to develop a little bit of edema there. So edema is a bad sign around nerve sheath tumors. So we asked them to biopsy, and we biopsied. So this was a grade 1 MPNST at that point. So these tumors go from neurofibroma to cellular neurofibroma to ATPR to malignant peripheral nerve sheath tumors. Just like your liver goes from normal liver to regenerative hyperplasia to adenomatous and then finally cancers. So you get all these gradual progression of increased cellularity as it gets malignant. Last point, when to give contrast. We give contrast for infections or tumors. So this is a case of spondylitis. You can see septic emboli in the lungs, and all these nerves are blurred and they're thickened and all that. So there's an infectious plexitis, both sides, right, more than left. You don't see the DRGs well. And here you can see the facet enhancement on contrast, etc. The other way to do that is you can do a contrast, and this we observed in 2010 before the first paper in 2015 came out, that we were doing a TOS protocol. We saw this case of CIDP I showed you before, and they wanted to rule out if there's any entrapment. So in TOS protocol, you do your 3D stir, then you do contrast, and you do a 3D stir after with arms elevated. And what I could find was all these tiny stuff, here and there, some vessels I could see, they all disappeared. So you could do contrast and do 3D stir after, and we're looking for kinking of nerves. We just saw these thickened nerves, no kinking of nerves, so we didn't call it TOS. And this was a contrast we're doing. But here is a case of radiation neuropathy where you have scarring around nerves. Now you elevate this, and you can see there's quite a bit of kinking, thick nerve, etc. And most of the vessels are gone. So if you don't have a good scanner, you can do contrast, and after that you can do a 3D stir. Okay, now moving to the signs. So we'll go through these quickly, and I'm not monitoring chat, otherwise if it's a longer lecture, I can ask you questions. But the whole idea here is, from my experience and what's in the literature, can we come up with certain signs which can give some clues to you that you can make a final diagnosis rather than just saying the nerve is bright or no, there's neuropathy, etc. So we have certain signs we have defined. So we're currently writing a paper on it. It's not in publishing yet. But let's go through tumor signs. So you have the spaghetti sign. So you guys who like Italian food, most of us like it. You can get that with these tumors. I can make it interactive if you want. Do you know what this tumor is? I'll have to log into another computer to see the chat. But maybe Gaurav can chime in if he sees any answers, any positive answers.
Yes, sir. So no questions so far for the neurography chat.
Okay. No, I was asking an answer for this. We can go faster, then we can take question in the end. So this is a spaghetti sign you see with fibrolipoma of the nerve. So there were different names previously: fibrolipomatous hypertrophy, idiopathic hypertrophy, fibrolipoma. Now the new WHO term is lipomatosis of the nerve. So this is lipomatosis of the nerve. It usually happens in median distributions. In this case, it's median nerve. In this case, the medial plantar nerve of the foot. So it gives you that spaghetti sign. Target sign, everybody knows. It's a peripheral nerve sheath tumor, usually neurofibromas, rarely in schwannomas. And you see these on ADC maps much better. So there's a colored ADC map. But if I showed you grayscale, the target signs sometimes are more apparent on ADC than T2. I showed this to one of my trainees, Shivani. I think she wrote a paper on this later on. Here was a case of radial nerve tumor. You can see this radial nerve coming out, and was from the radial nerve. And I called this benign tumor. ADC was also high, 2.1. I could see most of the tracts. The surgeon went back and he said, no, patient is really symptomatic. He's got a sudden wrist drop. He shouldn't be getting with a benign tumor. He's known NF. So you can see all of the tumors here. I said on imaging is benign. He said, no, we're going to get a PET. So they got a PET. It was negative. He still took it out. And this was a benign tumor. So you can be pretty specific with MR. And then this is another one. It's called the honeycomb sign. And this honeycomb sign are these spindle-shaped tumors you'd see in sciatic, femoral nerves, common peroneal nerve, rarely in the upper limbs. There are 1 or 2 case reports of upper limbs. We have seen a couple. But this basically gives you this honeycomb appearance. So all these fascicles are uniformly enlarged. Their ADCs can get to 1.1, so they're very tight tumors. And these are usually younger patients. So that's a perineurioma. The third one is Garland sign. So these are commonly seen with these intraneural ganglions in the common peroneal nerve or suprascapular, one of these nerves. So the idea here is that, I can show you on 3D, that you have a branch from the tibiofibular joint. In this case, there are 2 branches. In fact, the surgeon plugged one of these branches and the tumor came back with vengeance because he didn't plug the other one. So he had to go back again. So you may have one or two branches which you can see from the joint, and then they go along the path of least resistance back into the nerve and cause foot drop. This patient had about 15 years of stomping foot, 15 EMGs or so, and everybody said, "Oh, neuropathy. Oh, it's gone. Oh, neuropathy is gone." So if you do an MRI, you can see these ganglions which go in and out, and this forms a garland sign. The next one is bag of worms, where you see lots of tumors. In this case, sciatic nerves. This case, in the brachial plexus. So these are like worms, a lot of them. So that's a plexiform neurofibromas. Then you have this dripping hose. Dripping hose means that something is dripping out of the nerve from a thicker nerve. So it's not a sharp nerve, which I showed you. So you can see that with infections, you can see that with tumors. In this case, it's a lymphoma. And you can see that with very active CIDP, you can see a little edema around the nerve. So there are differentials for that. But most commonly, if it's enlarged nerve, low ADC, then you know you're dealing with lymphoma. Okay, next we go to the injury sign. So injury sign, the first one is gudgeon. Gudgeon is a freshwater fish, those who like eating fish. It looks like this. So this case came for carpal tunnel syndrome, but you can see there's a fish there, and it is continuous with the remaining nerve. So these are neuroma in continuity. There's a class 4 injury, and it turned out to be neuroma in continuity, what we called on imaging. The surgeon was only suspecting carpal tunnel. And here you have one in the ankle where somebody jammed a golf cart in their ankle, and you get a neuroma in continuity there. And this one is in the brachial plexus from the dirt bike injury, and you can see these neuromas in continuity. The next one is yawn ball sign, meaning you have a ball with a yawn, and that's an end bulb neuroma. So now the nerve is completely cut, and you can see it in the sciatic from a knee replacement. This is from iatrogenic, from thyroid dissection. They accidentally cut C5 and C6 nerves and form the yawn balls. The next one is loner sign. So this is a very classic sign for dirt bike injury, where the neck gets stretched out of the shoulder, and the only nerve which is left around is usually C5. So that's the loner nerve which is left around. And the surgeons get excited when they see this, because they can take the suprascapular nerve, sorry, not suprascapular, the intercostal nerves or the phrenic nerves, and connect it to the suprascapular axillary nerves, try to get the shoulder and elbow function back. But I told them that not only this is cut, it's very enlarged, first of all. Secondly, you see another high-grade injury here. So it's not going to be functional. And the surgeon said, "Oh, you know, this is our last chance, young patient." So they went in the OR, they did intra-op electrophysiology to see if there's any potential. And this was a dead nerve, basically nothing. And the rest of the nerves are sitting here. And you can see all these pseudomeningoceles and these tiny twigs of remaining nerves. This is the other side. You can see all the rootlets, which are normal. So here's another loner sign. The only thing left is this nerve here. The rest are all sitting here. And then you have rupture here, pseudomeningocele here, rupture there. Okay, the next one is whiteout or blackout, meaning the nerve gets too white, so you can't see any fascicles, or it gets too black. So in this case, you're seeing both. And these are classically class 6 injuries, where you have injury from outside in, not inside out like Sunderland classification. So injury from outside in, from knee dislocation, the nerve gets scarred down, and then it loses all its fascicles and it gets white here. Okay, the next one is for entrapment and inflammation. So one is Mount Fuji. So I was there recently, last year. It's a very small mountain, but it's a pretty mountain. In India, you have much larger mountains. And here you can see these kinking of sort of nerves, little peaks, which are formed by the fibrous bands from thoracic outlet syndrome. And that's for entrapment. The next one is meandering sign, like a river which is meandering. So nerves, when they become abnormal, they become tortuous. They start looking like all these vessels. So this is suprascapular nerve. How do we know it's going to the notch, it's going down? It's not branching like the vessels will branch. So this is a tortuous nerve from Lyme's disease. And then you have denervation here. So nerves start to meander when they become neuropathic. Then you have zigzag sign. So the nerves are not supposed to be zigzagging. They should be not having any angulation. So this is from scarring, or if you have under nerve reentrapment, etc., you'll see that scarring. So this nerve is under tension, and that's a problem. There is a Parsonage-Turner syndrome, where you can see these enlarged nerves, and now so this is an older case. With newer cases, you can also see these corkscrew-like changes or torsions around the nerves more commonly. But usually it's C5, C6 getting into the upper trunk and the suprascapular nerve. and then you start to get innovation there. But here is a more recent case sent to me by Faisal from Australia, and you can see these sort of tortuous, these torsions which happen along the nerve, and these may retorse back. This may become normal again. Is that zigzag again? So this is from re-entrapment. So in these cases, the nerve may be in so much tension that you may get infarct. So there's one infarct there, another one there. So nerves can get infarcted. They're really bad for the patient. They can't even wear the shirt. So these cubital tunnels shouldn't be done. If people are doing them, we frequently see re-entrapments. Almost 40% patients fail. So here's another zigzag from the first rib, which is articulating with the, cervical rib articulating with the first rib, and you see the pseudoarthrosis, that's kind of zigzagging nerve. So this was a piano player who couldn't play piano. And then after this was taken out, she could hold her hand up and do that and all that. She's crying in the recovery area that I could do it now. So that's the bony callus, that's the lower trunk, middle trunk, upper trunk, how it is enlarged and displaced. Okay, the next one is hourglass. So now you have, I told you about hourglass constrictions from torsion, but more commonly they can get with entrapments. When the nerve is enlarged and passing through a tight space, so this is radial nerve through the spiral groove. And there's a whole long story with this. We can talk some other time, but this you can see this hourglass shape, severely entrapped. And then triple B is basically white, black sign. So you have white, black, like that, along the nerve. So this was from IV cannulation, they injured the median nerve. So this is because of scarring around the nerve. So this can be seen with severe entrapments, can be seen with severe injuries, with infarctions in the nerves, and also from post-op grafts they can place. The graft can degenerate and give this black-white appearance. So again, it depends on the setting. You can come to a specific diagnosis. So we'll stop here. There's NSRAD system. You can read about it. I was going to cover this if we had full half hour, but I think we can stop here. And these are the signs. Try to use them in your practice. They will be in publication sometime later this year. I have so much on my table, so it's going slow. But I can take any questions you may have.
Thank you, Professor Chhabra. I think that was very detailed, right from the basics till most advanced about MR neurography. There are a couple of questions. There is one question. Please explain Garland sign.
Yeah, garland is like a garland of flowers. What it means is these bubbles of fluid which are going from the tip fib joint back into the common peroneal nerve. So if you see here, the fluid comes out of the joint, and so common peroneal nerve or any of these nerves have intra-articular branches. So there's tiny branches, these two branches which are part of that nerve. The fluid comes back as bubbles, retrograde along that nerve and forms this garland. So whenever you see a chain of beads or a garland going along the nerve to a longer distance, that's usually a perineural spread of that ganglion. It's not just a simple ganglion in the soft tissues. So you can see that radial sensory nerve, suprascapular nerve, obturator nerve. We are seeing with almost every nerve.
Got it, Professor. Next question is, can you please go over honeycomb sign again?
Yeah, honeycomb is this one. Oh, that's good. Just the next slide. So honeycomb is enlargement of the fascicles in a very uniform fashion. So these are perineuromas, meaning it's around the nerve fascicle. You have these sheaths and the cells which proliferate. They enlarge the whole nerve in a spindle shape. So previously these were all called as idiopathic hypertrophic mononeuropathy, or some were labeled as leprosy and all that. Then there was a big series, I think it was in 2009 from Mayo Clinic, or 10 in Brain. Brain was a journal, about 60 cases of perineuromas. The Mayo Clinic is interesting. It's like a private practice. So they have Kim Amrami was an MSK radiologist, and then Rob Spinner is a surgeon, and then they have Van Dyck, and there are a couple of guys who do neuropathology and EMG. So these 5 guys basically got together and published case series after case series. So one of the case series interesting was this one, the perineuromas. And then we started getting a lot of these. People started recognizing. So we saw a bunch of them in Hopkins, and I've seen several of them here in UT. So these are tumors which present in young age, number one. Number two, they give this spindle-shaped enlargement of the nerve. Third, they have only motor loss. They don't have any sensory changes. So the leg slowly dies, or the arm slowly dies, but arm is very uncommon, usually in the legs. And that's how we know now we're looking for something which causes motor loss. So what are those? You can have perineuromas, you can have multifocal motor neuropathy, usually in upper limbs. You can have polio, amyotrophic lateral sclerosis, Lou Gehrig disease, um, and motor only CIDP. So you can have these 4 or 5 things which can give you just motor loss. And perineurioma is one of them. Now, how do you distinguish that from all these other causes? It's only one nerve or the nerve distribution, meaning we start from sciatic plexus, go into sciatic and just the peroneum. Secondly, they have low ADCs. The other conditions I mentioned, all of them have high ADCs. Polio has atrophic nerves. Uh, Third, these all enhance homogeneously. So if you give contrast, it's very intense enhancement, just like lymphoma, but they have no necrosis, etc. Although we have seen a couple of cystic perineuromas, etc. But usually they're very tight fascicles like this, forming a honeycomb in large fascicles, very uniform.
Got it. Thank you. Next question is, can you confidently differentiate schwannoma for neurofibroma using MR neurography?
No, nothing is confidently. I mean, I usually say PNSD, and if it's an isolation, schwannomas are. So let's look at differences first, then we can come to how we can tell. Schwannomas are much more common than neurofibromas, number one. Number two, schwannomas may show you cystic changes, calcifications, hemorrhage. They don't have any underlying diagnosis unless it's schwannomatosis, which is rare. We saw a lot of them in Hopkins because there's a lady who's running a schwannomatosis clinic. But generally, these are rare as compared to neurofibromatosis. And it's a separate entity. It's like NF2 is gene 21, NF1 is gene 17, and schwannomatosis is a separate gene. Um, and then, so they're uncommon. They may show you these heterogeneous changes. Um, Target size is uncommon in schwannomas. And then their ADCs, again, we have a big series. I've gotten 3 students to work on it, but every time they start to working on it, they move somewhere else. In my experience, schwannomas usually have higher ADCs than neurofibromas. And then if you look at DTI, schwannomas have more traps than DTI on the neurofibroma. Neurofibromas have more disrupted traps. If you look at anatomic imaging, the surgeon will tell you that in a schwannoma, you usually have one fascicle coming in, one fascicle going out. They can see in microscopy. So that fascicle is a macrofascicle, not the microfascicle you see in histology. Similarly, on MR, we are seeing macrofascicles, like you see 10 fascicles in this nerve. You don't see 100 or 200, which are on histology. So that one macrofascicle on MR or on surgery coming in, coming out is a classic for schwannoma. Versus neurofibroma usually has either multiple fascicles or more concentric involvement of the nerve versus eccentric in schwannoma. So there are all these differences out there. So now when I'm reading a case and it's an isolated PNST, I'll just say, and the ADC is above 1.5, I'm just going to say it's a peripheral nerve sheath tumor, likely schwannoma, and then you make it ST-RADS 3. If you have any doubt, if you don't have any doubt, very classic target, no edema, etc., you can make 2 also, and then leave it there. Now, if the tumor is concentric, multiple fascicles, known NF, although there's a case report Laura recently published that in neurofibromatosis you can also get a single isolated schwannoma, but most commonly these all are neurofibromas. Then it's a neurofibroma, and then you have these different types of neurofibromas which you can diagnose. Say a diffuse neurofibroma, right? It happens in NF. Very classic appearance with skin, fibrous thickening of the soft tissues on the nerves. The second one is segmental form, which involves a leg. So it could be upper limb, could be lower limb. You have multiple nodules along that leg. Now, we have seen some segmental schwannomatosis and schwannomatosis syndrome also, but they are very rare. So I would almost always call that NF. If I see segmental or mosaic form, we call it neurofibromatosis. And then if you have bag of worms, that's, again, unless it's schwannomatosis, usually NF. So that's how you can tell, but you can never be 100% confident. And in the end, does it matter? Not really. Because what they're looking for is the ATP, or there's a new entity called BUNUP. BUNUP is like the benign unknown significance, which is in between ATP and high cellularity. So even pathologist is not sure, why do you want to be? So just call it peripheral nerve sheath tumor, make it SCRAT 2 or 3, depending upon do you see classic signs. If the ADC is dropping below 1.5, now you see it's getting cellular, or if there are cystic changes, necrosis, etc., developing, and it's a schwannomatosis, like ancient schwannoma, call it 3, but if it's neurofibromatosis, we call it malignant, call it 4 or 5, depending upon how big it is. So it's never a full science, but basically art and science and your experience.
Thank you. I think that answer in itself was a masterclass. Last two questions. How bright should a nerve should be to call it abnormally hyperintense? And should we use any other structure for reference?
Oh yeah, that's a complicated question. So it depends on the site. So let's start with plexus. This is your dorsal nerve ganglion, and the nerve should drop to half the signal and become smaller, uniform as you go in the leg. Right. If it's becoming brighter down there, there's some problem. It could be demyelinating plaque, it could be tumor, it could be cyst, or whatever is happening in the nerve. Now, when you look at the sciatic plexus itself, any nerve which is coming at an angle, this is going to have some transient increased signal. So, for example, if your common peroneal nerve branches out the sciatic and go under the fibular tunnel, so that area can be slightly bright. Okay? So, any nerve which is turning can have slight brightness. So, then you need to compare with the other side or see how bright it is. Is it approaching the, this goes back to a 2010-11 paper on sciatic nerves. If the fascicle of the sciatic nerve approaches the nearby vessel, the pain, if it's more than 90%, it's usually neuropathic. So how bright and which area? When the nerves get straight, meaning sciatic nerve going into the thigh, femoral nerve beyond the inguinal ligament, there should not be any brightness. So other thing is, don't make your images too contrasty. You have to have nice grayscale also. So that way you're not making the nerves very bright. Then the technique. So if you're doing PSRF images, most nerves are very dark on that. So any brightness is usually abnormal. If you're doing Mensa images or DES images, so let's say Mensa. So Mensa, when you images you're doing, the nerves are usually more brighter than you'll see on PSIF. If you're doing DES images, the nerves are less bright, meaning it's a less sensitive sequence. So I don't prefer DES unless I don't have a choice. It misses the signal changes. So PSIF is most sensitive and usually right. Mensa, very bright in most cases, so you have to make a sense of comparing with other nerves and see what's going on. And then DES is less sensitive in terms of those sequences. Now, if you do a 3D stir after contrast, that makes the nerves brighter. So what you have to do is you have to really like window it nicely and then again use those rules. Use the rule of DRG to nerve, compare to the other side, compare to the symptoms, and see if you're seeing focal areas of increased signal or not. Because it makes the nerves artificially bright. So it's all a grayscale in the end. If you make the images too black, everything else gets brighter. And then the ulnar nerve, median nerve, so nerves which are passing through the tunnels. So they may have subclinical neuropathies like EMG. If you do in them by aging, they'll say, oh, velocity is below 50 centimeters per second. Or now you're 70-year-old, it's 40, but maybe normal for you. So similarly, these nerves, the constant friction, the everyday activities you're doing, T1 nerve at the thoracic outlet, they may have a little bit of signal changes here and there. So you just ignore it. Unless it approaches the vascular signal or patient symptomatic, or you see flattening of the nerve, you see proximal enlargement, you see normal fascicles. So you look for other stuff beyond just a signal change. So again, it's a complicated question. It's nerve by nerve. So last one, like femoral nerve, when it comes out, I don't know if I have a case of femoral nerve here, but in femoral nerves, you will have increased signal of the DRG, then you'll have a drop of signal to normal, then just before the genu, meaning it curves like this before it goes under the inguinal ligament, that area will again become bright, then genu will be darker, and then after that it should be dark. So you have to know these appearances. And then the obturator nerve is the main reference center. Obturator nerve is never bright in the lumbar plexus. If that's bright, you got some plexopathy. And similarly, radial nerve in the upper arm is your reference standard. Tibial nerve in the lower arm, lower leg is a reference standard. They're never bright. So here you can see the tibial nerve is normal. So that's how you can compare and come to that. Again, it's an experience. I mean, I can't teach in one talk, but you have to do these cases to get a hold of these.
Got it, Professor. Thank you so much. I myself have one last question for you. What message would you give to someone who's entering and learning MSK ultrasound, MSK MRI? When it comes to only peripheral neuropathies, what would be the go-to investigation of choice? Whether it should be peripheral MR neurography or should be a peripheral nerve ultrasound?
No, you can do ultrasound also. Ultrasound is higher resolution. So now even when I said zero point 0.4 millimeter, you can get that's 400 microns. Ultrasound you can get to 150 microns. So the fascicles you will see the ultrasound are better in nerves which are accessible, nerves which do not have scarring around them. The things you are going to be seeing better. So it's like pancreas in abdomen. If you see it, patient is fasting, you're going to see it the best, better than MRI. But if you don't see it, you don't see it. So, so the first thing is the visibility and accessibility. Second, availability of ultrasound probes. They're quite cheap. Yesterday I bought one for our medical camp. We do a charitable medical camp. It's only $2,600, and that ultrasound you can use on your phone, iPad, and all that. It goes up to 13 megahertz. And so it's the availability. So if you have it availability, you have the skill, you have the accessible nerve, why not? Now you have to remember what the disadvantages are. The disadvantages are that you're not going to see signal changes till the nerve is very abnormal. Then it starts to become hypoechoic and all that. Second, um, any sort of muscle changes, unless they are advanced like grade 2 and 3 and 4, you're not going to see them. So early denervation, you're going to miss. Um, Third, if you have any post-op scarring or any sort of intervention there or injuries there, etc., then it can be an issue that the nerve may not be seen very well. So yesterday I was asked to look at medial proper digital nerve at the great toe, and patient had this hallux valgus fixation to the dorsal plate, and the tech had seen a black area there, a thick black area, and she said it looks like it's continuous up and down. And we press there and all that. So the other advantage ultrasound gives you sonopalpation. You can do a sonographic tunnel sign, or you can press it and all that. So patient is completely non-tender there. You're just feeling a lot of glove-like feeling at the bottom of the foot. And then when I tried to trace this medial plantar nerve, this is a 20 megahertz I was using, I could not get below the midfoot area. I couldn't see the nerve. Right? So now you have lack of visibility of that tiny nerve, which on MRI you can pick up. You have post-op distortion by scarring. So that was basically, I ended up calling all of that as callus and scarring, the nodular scarring, but not a nerve. But the advantage I had was I could press on it. I say, oh, this is not tender. And if this was a nerve and this is a thick nerve there, then I'm going to see nerve below and above. I didn't see anything above and below. So that's not a nerve, it's just callus. So it has all advantages, disadvantages. So when you're starting out, I would start with whatever you have. So use all the tools possible. Like when I read a spine MRI, I always look at the X-ray also, is there transition vertebra and all that, part fracture, etc. So use whatever you have, but you got to know the limitations and all that. So you always have a fallback modality.
I think that very well answers the question, and thank you so much for delivering the right message. I have last one question for both of you is, can you list down 2 reasons why people should come and join us in Mauritius to attend this summit?
2 reasons. Well, the first reason is it's the location. It's beautiful location. They always say in conferences you want to have good location. So I go to very few US conferences because first of all it's less learning at my stage, and the location may not, maybe already I've seen it or I've visited and all that. And it's too expensive probably, or Asia is cheaper. So one is location. So Mauritius is a beautiful place. You should go. Second, meeting everybody in person, and then you'll be hearing all sorts of these kind of pearls from our experience, skills, all that. Dr. Botchu has published thousands of papers, so he knows ins and outs of all the radiological science. So you can learn a lot in 3 days. And Dr. Sharma, I mean, he's authority in all these ultrasound interventions, biologics, and I don't do all these biologics, So you have unique skills which are coming. Then you have skills coming from Greece, from Elena, Dr. Nizar, and Girish Kandikata. I mean, they're all these people who will share a lot of stuff with you. I think you should come and let's meet in person, enjoy, have a drink together.
Right.
Yeah.
So
I second
just
everything what he says. From my side, I think the most important thing is whenever you want to become a radiologist, you need somebody just in case to help you in complex cases and help as well. And also as a friend. Tomorrow morning, you don't know who you need. And so I think it will help you to for networking and also for support. And from my side, I can say from the first IMS, I have published papers with all the faculty. I have published papers with quite a few of the delegates who I only met during Mauritius, and they are still friends, though I've not met them in person after that. So it's a good place to come to relax, enjoy, and Mauritius people are amazing as far as hospitality is concerned. So I hope to see you all there.
Yeah, I just want to conclude. Thank you, Professor Bochu. Thank you, Professor Chabra, for joining us today. And I think it was a lot of learning for everyone. And you want to learn more about MR neurography, you want to learn more about nerve ultrasound interventions. So one big problem we have tried to address with this event this time is we really don't have a conference. It's 3 days, three different workshops: a DICOM MRI workshop, ultrasound workshop, and a MSK interventions workshop. So small group learning. It's not a big conference. Small group learning, a lot of interactions, and as Dr. Chabra said, it's a vacation where you are going to take a significant amount of learning and put it back into your practice. So I hope to join some of you there. We have last 5 days for the super early bird registration to close, and the website is mskies.org, mskies.org. So any of you have any questions, you can reach out to us. The email is contact@mskis.org. You can email us, you can message me, you can message any of the faculties, you can reach out to us. Any questions, anything, we'll be happy to help you. And we'll be doing our next webinar on the 11th or 12th of June. We'll announce the date tomorrow, which will be on MSK ultrasound. Thank you all for joining, and I hope you got good value out of your time being here with us. Thank you. Thank you,
Thank
everyone.
you. Take care, everyone.
Thank you.